Assalamu alaikum. Greetings, my dear doctors, and welcome everyone to our Mrcp UK Part 1 past paper course. And our today's topic would be August 24 diet.
A 56-year-old woman presents to her general practitioner with a 6-month history of pain and swelling in her hands and wrists. She reports morning stiffness lasting more than an hour, which improves with activity. On examination, there's tenderness and synovitis in multiple small joints of the hands. Blood tests reveal elevated levels of inflammatory markers and a positive rheumatoid factor. What is the most likely X-ray feature of this patient? Bony erosions, osteophytes, penicillin cup deformity, subchondral sclerosis, uniform joint space narrowing.
So, what is the most likely diagnosis?
Rheumatoid arthritis.
Rheumatoid arthritis.
So, this is a case of rheumatoid arthritis, and the duration is 6 months, pointing towards the early rheumatoid arthritis. Within 2 years, the rheumatoid arthritis is considered as an early rheumatoid arthritis. So, what should be the most likely X-ray features in case of early rheumatoid arthritis?
Bony erosions.
Yes, we'll get the bony erosion. Bony erosion is the most likely X-ray features in case of early rheumatoid arthritis. And what should be the X-ray features of osteoarthritis? What should be the X-ray features of osteoarthritis?
Subchondral sclerosis.
Yes, there would be subchondral sclerosis and other features.
Osteophyte.
Yes, there would be. So in case of early rheumatoid arthritis, we'll get the features of marginal bony erosion. And in case of osteoarthritis, we'll get the marginal osteophyte, subchondral cyst, subchondral sclerosis. And there will also be the joint space narrowing. Joint space narrowing is always present in case of osteoarthritis. Joint space narrowing may be present in the advanced stages of rheumatoid arthritis, but with regards to joint space narrowing, we'll always consider the osteoarthritis as the first differential diagnosis. And with respect to the portion of the joint involved, in case of rheumatoid arthritis, usually non-weight bearing portion would be involved. And in case of osteoarthritis, the medial portion of the joint would be involved. So if we consider the knee joint, so in case of knee joint, the lateral portion is the non-weight bearing portion. So in case of rheumatoid arthritis, the lateral portion would be affected, and the medial portion of the knee joint, this is usually the weight bearing portion. So in case of osteoarthritis, the medial portion would be involved. So since this is the early rheumatoid arthritis, we will get the features of bony erosion, and this bony erosion, it also carries the poor prognostic features in case of rheumatoid arthritis. So what are the other poor prognostic features of rheumatoid arthritis? Poor prognostic features.
Anti-CCP positive.
Yes, anti-CCP positivity. This is the poorest indicator. Whenever patient is having the anti-CCP antibody, it usually carries the worst prognosis, and this is also related to the aggressive joint destruction. And other poor prognostic factors would be rheumatoid factor positive, poor functional status at presentation, and whenever there is early erosion occurring before 2 years, whenever there is extra-articular features like the nodules, or association with the HLA-DR4, or whenever there is any insidious onset. And with respect to the rheumatoid arthritis, what can be the pattern of instability which usually occurs involving the spine in case of rheumatoid arthritis? Pattern of spine instability in case of advanced rheumatoid arthritis. This is a little bit difficult question. So usually there are 3 types of spinal instability that can occur in case of advanced rheumatoid arthritis. the rheumatoid arthritis is the most common inflammatory disease involving the spine. It has a predilection for the craniocervical spine. So within the spine, usually the craniocervical portion is more commonly affected. The three different patterns of instability which can result are the atlantoaxial subluxation, atlantoaxial impaction, and subaxial subluxation. And usually the atlantoaxial subluxation, this is more commonly encountered in the exam. So whenever the distance between the arch of the atlas and the odontoid peg, this is greater than 2.5 millimeter, this is regarded as atlantoaxial subluxation. And this atlantoaxial subluxation, it can occur either due to erosion of the odontoid process or due to laxity of the transverse ligament from the rheumatoid pannus, resulting in the posterior subluxation of the odontoid. And ultimately, this atlantoaxial subluxation, it can lead to the cervical cord compression. And whenever this type of instability is suspected, choice of investigation should be the MRI. So penicillin cup deformity, this is found in which condition? Pencil in cup deformity.
Hyperparathyroidism.
Sorry, in case of hyper. Penicillin cup deformity, this is found in case of advanced psoriatic arthritis. Okay, P for pencil, P for psoriatic arthritis. Penicillin cup deformity, this is found in case of advanced psoriatic arthritis. So whenever one end of the bone, they become tapered like a pencil, fitting into an eroded cup that is shaped to an end of an adjacent bone. This is known as the penicillin cup deformity. And other features, subcondylar sclerosis, osteophyte, they are the predominant features of the osteoarthritis. And uniform joint space narrowing, this is found in case of advanced rheumatoid arthritis. But here the scenario is the early rheumatoid arthritis. So the most likely findings would be the bony erosion. And in case of advanced stages, usually after 10 years or 15 years, you can also see the uniform joint space narrowing. In rheumatoid arthritis, one of the hallmark features on X-ray is the bony erosion, which results from chronic inflammation leading to bone destruction at the margin of the affected joints. This marginal bony erosion are often seen early in rheumatoid arthritis and can be a diagnostic feature distinguishing it from other forms of the arthritis. The presence of these erosive changes correlates with the disease severity and the progression. And osteophyte, these are the bony outgrowth commonly associated with the osteoarthritis, and they usually occurs as a part of regenerative or reparative response to the cartilage degeneration. And penicillin cup deformity, this is the feature of advanced psoriatic arthritis. So P for P. It described severe erosion where one end of the bone becomes tapered like a pencil, fitting into an eroded cup-shaped end of an adjacent bone, typically seen in advanced stages. Subcondylar sclerosis, this is also found in case of osteoarthritis due to chronic wear and tear process. And this sclerosis, this refers to the increased density or hardening beneath the cartilaginous surface, and it will appear as more whitish in the X-ray or in the CT scan. And uniform joint space narrowing, it can occur due to the synovial proliferation causing the cartilage destruction and reflecting the advanced rheumatoid arthritis changes. Marginal erosions are considered pathognomonic of early findings in rheumatoid arthritis. So in case of early rheumatoid arthritis, you will get the marginal erosion, or you can also get the juxta-articular osteopenia, and in case of advanced stages, you will get the uniform joint space narrowing. And in our original scenario, the scenario was a little bit different, but the answer was same. It was the marginal osteophyte. So in the original scenario, instead of the 6 month, it was the 2 years patient with the rheumatoid arthritis, and within 2 years, still this is considered as an early rheumatoid arthritis. And they have given which features would be present: marginal erosion, periosteal lesion, joint space narrowing, osteophyte. The answer was the marginal erosion. And this marginal erosion, these are the hallmark of rheumatoid arthritis, and they usually results from the inflammatory process eroding the bone at the edge of the joint, and they are also commonly observed in the early stages of the rheumatoid arthritis and can easily be detected on the X-ray. And joint space narrowing, osteophyte, these are the features of osteoarthritis. Okay, next one, please.
A 66-year-old man presents to the emergency department with a 5-day history of fever, productive cough, and pleuritic chest pain. On examination, his febrile at 38.5 degrees Celsius, confused, tachypneic, with a respiratory rate of 32 breaths per minute, and has reduced breath sounds on the right side. A chest X-ray reveals consolidation in the right lower lobe with an associated pleural effusion. What is the most appropriate management? Administer IV antibiotics and arrange for thoracocentesis, admit for observation and repeat chest X-ray in 48 hours, initiate for oral antibiotics and follow up in 1 week, perform immediate bronchoscopy, or prescribe diuretics to reduce the pleural effusion.
This is administer of IV antibiotic and arrange for thoracosynthesis.
Yes, very good. So what is the most likely diagnosis here?
Pneumonia.
So this is a case of pneumonic consolidation associated with the pleural effusion, and the most appropriate management would be the administration of IV antibiotics and arrange for the thoracosynthesis. So since this is a case of pneumonia, so calculate the CARB 65 score in this scenario.
This is
Three.
2.
3.
No,
Confused
3.
patient.
This is 3. Confusion is present also. 3.
So number 1.4, age is greater than 65, 1 point. Another point for confusion, and third point for whenever the respiratory rate is greater or equal to 30, this also indicates another point. So 1, 2, 3. So the CARB 65 score is 3. So what should be the management protocol for this patient presenting with CARB 65 score? When the CARB 65 score is 3, where the patient should be treated and what should be the choice of antibiotics? So in the
ISO
secondary
in
care
hospital.
setting, whenever the patient is admitted, so initially before admitting the patient, we usually omit the urea from the assessment. In the primary care setting, we go with the CRB 65, but whenever the patient is admitted in a secondary care setting, we go for the CARB 65. So C for confusion, meaning the abbreviated mental score, it should be either equivalent to 8 or less than 8. Elevated urea level greater than 7. R for respiratory rate greater or equal to 30. And B for the blood pressure. So whenever the SBP is less than or equivalent to 90, or the diastolic BP, this is less than or equivalent to 60, here is also 1 point. And another one is if the age of the patient is greater or equal to 65. So all of them, each of the point, they will carry the 1 point. So so each component of the CARB 65 score, they are also the poor prognostic features, and each of the point they will usually carry the 1 score. The PTS guideline on the community acquired pneumonia in adult recommend use of CARB 65 tool in conjunction with the clinical judgment. The CARB score is calculated by assessment of core adverse prognostic features, which are used in assessment of severity of the pneumonia. So this is based on 5 parameters, and each of the parameter will carry 1 point. So CURB 65, curve 65, each of them will carry 1 point. And always remember, the confusion should be new onset confusion. So whenever the urea level is greater than 7, this is also one of the criteria equivalent to 1 point. And also all the points in the curve 65 score, they are also the poor prognostic factors. And whenever the question related to pneumonia will be tough, so they usually ask regarding the poor prognostic factors, and they will also ask regarding the score based treatment. So all the points of curve 65 score, they will carry the poor prognostic features like the age greater than 65, coexisting morbidity including the diabetes mellitus, congestive cardiac failure, coronary artery disease, stroke, chronic lung disease, respiratory rate greater than 30, then either low SPP or low DBP whenever there is bilateral involvement, or involvement of more than 2 lobes on the chest radiograph, or whenever there is altered mental status. And there are some of the biochemical or hematological markers like the white cell count either less than 4 or more than 20. Whenever there is hypoxemia or the patient requiring the FiO2 greater than 60% to maintain the saturation, positive blood culture, or whenever there is blood urea greater than 7. And there are also some other features of severe pneumonia, but to remove the confusion, you can just memorize the criteria that are related to the poor prognosis. So the next chart is based on the score based treatment. So in case of low severity, whenever the score is 0 to 1, this is regarded as low severity. Mortality rate is less than 3%. When the score is 2, this is regarded as moderate. When the score is 3 to 5, this is regarded as high severity, and mortality is 15 to 40. So in this scenario, the curve 65 score is 3, pointing towards the high severity, and the mortality rate of the patient would be 15 to 40%. So whenever the score is 1 to 2, then you should go for the hospital admission should be considered. And whenever the score is 3 or more, then hospital admission is warranted. So score 0 or 1, you can go for the home-based treatment. When the score is 2, you can go for the inpatient treatment, especially or you can alternatively, you can also consider the hospital supervised outpatient treatment. And whenever the score is 3 or more, the patient should always be treated in the hospital. And whenever the score is 4 or 5, or in other guideline, whenever the score is 3, then the patient should be treated in the critical care unit, either in the ASTU or in the ITU. Also, let me show you the treatment based on the scoring. And whenever you will get the multilobar shadowing or cavitation, then always consider the Staphylococcus aureus. So in case of low severity cases, when the score is 0 to 1, you can go for amoxicillin 500 milligram 3 times daily. When the score is 2, you can go for amoxicillin 500 milligram or 1 gram 3 times daily, plus clarithromycin 3 times daily. And alternative regimen are also available for the penicillin allergic patient. And in case of high severity case, meaning in the scenario the score is 3, and whenever the score is 3 to 5, you should go for the IV coamoxiclav 3 times daily, plus oral clarithromycin 500 milligram twice daily. So for low and moderate severity, meaning from 0 to 2, you can go for the oral route. But whenever the score is 3 or more, you should always go for the parenteral antibiotics. And in uncomplicated cases, you will be going for 7 days of antibiotic treatment. But in case of high severity cases, whenever the organism is not identified, then the patient should be treated for at least 7 to 10 days In some cases, it can be extended up to 3 weeks. The presence of pneumonia complicated by a pleural effusion necessitates prompt intervention. IV antibiotics are indicated due to severity of this patient's presentation, like fever, confusion, tachypnea. His CARB 65 score is 3, which suggests a serious bacterial infection that requires aggressive treatment. Thoracosynthesis is crucial both diagnostically to analyze the pleural fluid characteristics such as pH, glucose level, cell count, and the culture, and also therapeutically to relieve the symptoms if there is significant fluid accumulation. This approach ensures both adequate infection control as well as the symptomatic relief. And regarding admission for observation and repeat chest X-ray for 48 hours, delaying the definitive treatment such as thoracosynthesis can result in further complication, including the empyema. And regarding initiate per oral antibiotic, follow up in 1 week. So the score is 3, pointing towards the severe community acquired pneumonia, and you need to go for the IV antibiotics. And with respect to the diuretics is usually indicated for the transudative pleural effusion, like for the heart failure or for the hepatic failure. But in this is the pneumonic consolidation. It falls under the exudative pleural effusion. And in the original scenario, it was a little bit different. So pneumonia initially responding to antibiotics. Now the patient has comes up with the intermittent fever. On examination, there was a right-sided pleural effusion, and they have asked what should be the next step in management, or what should be the next step. So options were the thoracosynthesis, CT scan, and the sputum culture. So we'll be going for the thoracosynthesis. So usually in a patient with the pneumonia, initially responding to antibiotics, so whenever there is intermittent fever and right-sided pleural effusion, the next step would be the thoracosynthesis. This thoracosynthesis, this is usually performed to obtain the fluid from the pleural space for analysis. This is crucial for diagnosing the cause of pleural effusion and whether this is either due to infection such as parapneumonic effusion or emphysema, or as part of the other etiology. Analyzing the pleural fluid helps determine the presence of infection and its nature, whether this is bacterial or tuberculous, and it will also help us to guide for the further treatment. And this thoracosynthesis, it can also help us to provide the symptomatic relief by removing fluid that may cause discomfort or difficulty breathing. And with respect to the CT scan, so CT scan can be useful for further evaluation of the pleural effusion and to assess for complications such as loculated effusion or lung abscess, but this is not the immediate next step if the primary concern is to address and analyze the pleural effusion. So the next step would be thoracosynthesis, and depending on the thoracosynthesis interpretation, we can decide whether the patient will need CT scan or not. So this thoracosynthesis, it will allows for the direct assessment and management for the pleural effusion, and CT scan should only be performed when the thoracosynthesis result is either inconclusive or further anatomical detail is required. Okay.
A 20-year-old woman presents to the general practitioner with a 2-month history of suddenly stopping and staring in the middle of activities or conversations. These episodes last for a few seconds, after which she can resume her conversation without any confusion. She reports smoking cannabis on weekends, and recently her parents have informed her they're getting a divorce. What's the most likely diagnosis? Anxiety, cannabis-induced psychosis, dissociative disorder, focal awareness seizure, or panic disorder.
Isn't it focal awareness seizure?
Also, the
Yes, even I go
most
with that.
likely diagnosis is the focal awareness seizure, and if we go for more specific, then it can be either an absence seizure or an simple partial seizure. So this patient has comes up with the sudden stopping and staring in the middle of the activities or conversation lasting only for a few seconds. So this is highly suggestive of the seizure, and the fact that the patient has resumed her activity without confusion. So this support that the seizure type, it does not impair the consciousness completely, pointing towards the focal awareness seizure. And with respect to her cannabis use and stress related to the parents' divorce, so it can contribute to the psychiatric symptoms, but the specific description of the episode, it strongly points towards the neurological cause rather than an psychological ones. And with respect to the anxiety, so in case of anxiety, patient usually comes up with the features of palpitation or sweating, or there may be a longer duration of distress, and abrupt cessation of activity without emotional or physical symptom. This is also atypical for the anxiety. And with respect to the cannabis induced psychosis, so this condition, this usually involves the more severe symptoms like the hallucination or delusion or significant alteration in the perception rather than just transient staring spell or with the rapid recovery. And cannabis induced psychosis, it will involve the hallucination or delusion or disorganized speech. And with respect to the dissociative disorder, so in case of dissociative disorder, there would be disruption in the identity, memory, or consciousness, meaning there would be prolonged period of detachment from the reality, and it often occurs in the context of an severe emotional stress. But here the scenario given here is a sudden brief episode lasting for around seconds. And with respect to the panic disorder, so panic disorder usually involves the intense fear or tachycardia, or in some cases the features of hyperventilation associated with the physical symptoms. So this sudden cessation of seizure activity and staring episode lasting for a second and resumption of activity without confusion, it indicates the focal seizure where the awareness is preserved. So this is our focal awareness seizure. And what should be the investigation of choice in this patient? What should be the choice of investigation? Whenever the focal seizure or generalized absence seizure is suspected, you'll be going for the EEG, electroencephalogram, to confirm the diagnosis. Focal awareness seizure, previously known as the simple partial seizure, is characterized by a brief episodes where an individual may stop their activity and appear to stare blankly but retain awareness during the episode. After the events, they can typically resume their previous activity without confusion or memory loss regarding what happened during the seizure. The patient's symptoms align well with this description. She experiences sudden staring spells, yet remains able to continue conversation post-episode seamlessly. While her cannabis use and recent stress due to her parents' divorce can be contributing factors, these elements do not directly account for such stereotypical episodic behavior. And
Sir, what would be the treatment?
for the
Levetiracetam.
you'll be going for the since the patient is within reproductive age group, so you'll be going for the levetiracetam. And in case of male patient, you can go for the sodium valproate. So in case of cannabis-induced psychosis, there should be features of hallucination, delusion, or significant alteration in the perception. And dissociative disorder will involve the disruption in identity, memory, or consciousness. And panic disorder, this is always associated with the physical symptoms. And in the original scenario, it was a little bit complicated. Complex partial seizure. So a 22-year-old female with the multiple attacks of loss of consciousness but not falling down. She was helped in sitting down by her parents. Recently, she has been told regarding separation of her parents. During the attack, she freezes up every time for 20 minutes. Then after a while, she came back to normal. She has some episodes in which she stares at the same thing with her impaired awareness. And after the event, she became completely normal, no loss of the muscle tone. And the diagnosis was the complex partial seizure, also known as the focal impaired awareness seizure. So this type of patient will have either freezing up impaired awareness or staring and impaired awareness, and the duration is usually short lasting, and there would be no loss of the muscle tone.
A 32-year-old woman presents to a general practitioner with a history of recurrent abdominal pain and palpable bilateral flank masses. She has a known diagnosis of tuberous sclerosis complex. On physical examination, multiple hypomelanotic macules are noted on her skin, along with subungual fibromas. Which renal finding is most likely in this patient? Autosomal dominant polycystic kidney disease, angiomyolipoma, glomerulonephritis, renal cell carcinoma, or renal cyst.
Renal cell carcinoma.
So this is a case of TSC, tuberous sclerosis complex. So most commonly associated renal abnormality in case of TSC.
Angiomyolipoma.
Angiomyolipoma.
Yes, very good.
B.
So this type of patient will have the multiple bilateral angiomyolipoma. This is the most common renal manifestation in a patient with tuberous sclerosis. So patient with tuberous sclerosis, patient develop renal angiomyolipoma, which are usually prone to the hemorrhage. So this is the most common renal manifestation in a patient with tuberous sclerosis. And whenever you get a patient with acne, sebaceum associated with the hyperpigmentation, consider the tuberous sclerosis. And other than the angiomyolipoma, the lung cyst or other simple cyst, it can also be associated, but always remember the angiomyolipomas. And there are also other important features of what are the 4 cardinal features of tuberous sclerosis. So one is the ash-lip macule, another one is the adenoma, sebaceum, ungual fibroma, and the renal hamartoma. So these 4 are the cardinal features of the tuberous sclerosis. So you can remember with the mnemonic AUR, ash-lip macule, meaning the depigmented skin patch, adenoma sebaceum, meaning the red spot or papule, usually involving the nose or nasolabial fold or cheek or chin. There may be ungual fibroma. There will be smooth fleshy growth adjacent to the fingernails, and retinal hematoma. So there would be translucent rounded lesion exhibiting from the retinal periphery, and invariably they will have a history of the seizure, and choice of investigation should be the MRI of the brain. Angiomyolipomas are the most common renal manifestation in patients with the TSC. These are the benign tumors that are composed of blood vessels, smooth muscle cells, and the fat cell. This can lead to various complications such as hemorrhage due to their vascular nature. Patients with TSC, they are often present with multiple bilateral angiomyolipoma, which can be detected from the imaging studies such as ultrasound or MRI. And in case of ADPKD, there is usually mutation in either PKD1 or PKD2 gene. So which mutation is more common? 1 or 2?
PKD1.
Yes, PKD1 is more common, most probably around 80 to 85%. And the simple renal cyst can also be found in case of TSC, but the most common association, most common renal manifestation are the angiomyolipomas. So also in the original scenario, it was a case of tuberous sclerosis, and they asked most likely renal abnormality, and it was the angiomyolipoma. Angiomyolipoma is the most likely renal abnormality associated with the tuberous sclerosis. And this angiomyolipoma, these are the benign tumor composed of blood vessels, smooth muscle, adipose tissue. These are commonly found in the kidneys of the patient with the tuberous sclerosis. And up to 50 to 80% of individual, they can ultimately develop the renal angiomyolipoma, and in most of the cases they are usually asymptomatic, but it can also lead to the complication, and whenever there is complication, there will be either features of bleeding or renal impairment. And with respect to the renal cyst, simple renal cyst can also occur, but these are usually less specific for tuberous sclerosis compared to the angiomyolipomas.
A 45-year-old man presents to the emergency department with acute onset of severe weakness, nausea, and vomiting. He was recently diagnosed with high-grade non-Hodgkin lymphoma and has just completed his first cycle of chemotherapy. Physical examination reveals dehydration, and laboratory tests show elevated potassium, phosphate, and uric acid levels. Which of the following biochemical abnormalities is most likely to be seen in tumor lysis syndrome? Elevated calcium, elevated bicarbonate, elevated glucose, elevated urea, or low sodium?
So what should be the
Elevated calcium.
elevated, which one? What should be the which
Urea.
biochemical abnormality
Elevated
will be
urea. Calcium.
in case of
Urea. Low
tumor
calcium.
lysis syndrome? Calcium or urea or sodium?
Urea.
Calcium will be low.
Yes, calcium would be low. So why the urea level is elevated in case of tumor lysis syndrome?
Because of AKI due to rhabdomyolysis.
Yes, very good. So
Sorry.
not due to rhabdomyolysis. So the elevated urea in case of tumor lysis syndrome, this usually occurs due to the AKI, acute kidney injury, which is usually caused by the metabolic disturbances associated with the massive tumor cell breakdown. So in case of tumor lysis syndrome, there is usually the rapid lysis of the tumor cell, often following the chemotherapy, or it can also be as a result of spontaneous high turnover tumors, like in case of leukemia or lymphoma, as in this scenario. So this rapid lysis of the tumor cell or high turnover, this usually leads to the release of the intracellular contents into the bloodstream. So when it releases potassium, there would be hyperkalemia. When it releases phosphorus, there would be hyperphosphatemia. And whenever it will release the nucleic acid, then there would be hyperuricemia, elevated urea level. And there is usually release of nucleic acid due to catabolism of the purine into the uric acid. So the high levels of uric acid, they usually overwhelms the renal excretion capacity. And the uric acid, they will crystallize in the renal tubules due to the acidic nature of the urine, causing both obstructive uropathy as well as the AKI. And this AKI, it will impair the kidney's ability to excrete the nitrogenous waste product like urea, leading to the elevated urea level. So one pathophysiology of elevated urea level is the uric acid precipitation as a result of obstructive uropathy or AKI. And second pathophysiology is the hyperphosphatemia induced nephrocalcinosis. And the third pathophysiology would be the increased protein catabolism. So whenever there is hyperphosphatemia, the released phosphate, they will bind to the calcium, forming the calcium phosphate precipitant. And this calcium phosphate precipitant, it will deposit in the renal tubule, further worsening the renal injury. And the third pathophysiology, the increased protein catabolism, the tumor cell breakdown, it will lead to the increased metabolic load, including the protein catabolism. And the breakdown of protein, it will generate the nitrogenous waste like the ammonia, and this ammonia is converted into urea in the liver via the urea cycle, and it will also contribute to the elevated urea level in the setting of reduced renal clearance. So in summary, the AKI is caused by the uric acid crystal deposition and calcium phosphate precipitation, and the increased nitrogenous waste product from the tumor cell breakdown as well as the protein catabolism. And this elevated urea, this is one of the marker of the renal dysfunction in case of tumor lysis syndrome, and it will also lead to the uremic symptoms like the nausea, vomiting, as well as the altered mental status. So how to manage a case of tumor lysis syndrome, prophylaxis and treatment. What should be the prophylaxis of tumor lysis syndrome and what should be the treatment?
Raspberry juice.
Good hydration
Yes,
and
what is the raspberry acid? So raspberry acid is for treatment or for prophylaxis?
For both we can give.
Yes, very good.
For
Raspberry acid
prophylaxis.
can be used. Raspberry acid can be used both for prophylaxis as well for the acute treatment. So for the management of tumor lysis syndrome, we need to go for the aggressive hydration to maintain the urine output. Then after that, we can go for either allopurinol or raspberry acid. And also we need to manage the electrolyte imbalance. So in case of tumor lysis syndrome, only the calcium would be low. There would be hypocalcemia and everything else would be elevated. Rest potassium, phosphate, uric acid, LDH, and the creatinine. So everything would be elevated except the calcium due to the formation of the calcium phosphate precipitants. So high uric acid plus renal impairment following chemotherapy, go for the most likely diagnosis is the tumor lysis syndrome, and for the management we need to go for IV fluid and the raspberry acid. So raspberry acid, it can be given both for prophylaxis as well as treatment. And allopurinol is only for the prophylaxis, and in case they asked for the prophylaxis and both allopurinol and raspberry acid is given in the option, then you will be going for the raspberry acid. And also remember, the raspberry acid can be given both for prophylaxis as well as the acute treatment, but there is a difference in the dose. In case of prophylaxis, we need to go for the low prophylactic dose, 3 microgram per kg. And in case of acute treatment or acute management, we need to go for the treatment dose, meaning high dose resveratrol acid, 200 microgram per kg. So 200 for the treatment and 3 for the prophylaxis. Resveratrol and allopurinol should not be given together in the management of tumor lysis syndrome, as this reduces the effect of resveratrol. So what is the mode of action of resveratrol? Mode of action. What is the mode of action of resveratrol? This is very important for part 1. What is the mode of action of resveratrol? Anyone?
Urate oxidase inhibitor.
Covaxificasi jalan teng.
This is the recombinant urate oxidase. Resveratrol is the recombinant urate oxidase, and this is commonly used either in hematological malignancy or in case of acute urate nephropathy. And benzbromarone, this is URAT1 inhibitor, and lesinurad is the urate1 and urate4 inhibitors. Tumor lysis syndrome, it occurs due to rapid breakdown of the malignant cell after chemotherapy, leading to release of intracellular contents into the bloodstream. This includes nucleic acid, which are metabolized to uric acid, subsequently leading to hyperuricemia. The excess uric acid, it can precipitate in the renal tubules, causing acute kidney injury, which further increases the blood urea level as renal clearance decreases. Therefore, elevated urea levels, these are the hallmark features in patients suffering from the tumor lysis syndrome. In TLS, there is formation of the calcium phosphate crystal. This, along with the formation of uric acid crystal, is the main cause of AKI due to accumulation of the renal tubules. The formation of calcium phosphate crystals result in a reduction rather than in an increase in the serum calcium level. An elevated bicarbonate level would typically indicate metabolic alkalosis, and in case of TLS, we will get the metabolic acidosis due to an accumulation of the uric acid and lactic acidosis as a consequence of the AKI. Hyponatremia, it may occur secondary to various factors such as fluid retention and as a part of SIAD's secretion. And in the original scenario, it was a little bit different answer. It's the nucleic acid. So it was a patient with the tumor lysis syndrome, and they asked what causes a rise in the urea. So the urea would be elevated due to release of intracellular nucleic acid. So due to the release of intracellular components into the bloodstream, there would be elevated potassium, there would be elevated phosphate, there would be elevated urea level. So urea level is due to release of intracellular nucleic acid. So when the tumor rapidly lyses, they release their intracellular contents into the bloodstream. This includes the nucleic acid, DNA and RNA, which are broken down into purines, then further metabolized into the uric acid. The increased level of uric acid in the blood lead to formation of the uric acid crystal, which can precipitate in the renal tubules, causing acute kidney injury and worsening the rise in the urea. And as the kidney function deteriorates due to precipitating crystal and overall increased metabolic load, the kidneys struggle to excrete nitrogenous waste product like urea. Consequently, blood urea nitrogen BUN level would be raised.
A 32-year-old man presents to the general practitioner with a widespread non-itchy rash that appeared 2 weeks ago. He also reports feeling generally unwell, with a sore throat and swollen lymph nodes. On examination, there are multiple small ulcers in his mouth and condylomata lata on his genitals. His past medical history is unremarkable, but he mentions having had multiple sexual partners in the past year. What is the most appropriate antimicrobial treatment for this patient? Ceftriaxone, doxycycline, fluconazole acyclovir, or benzathine penicillin G?
So most
Benzathine
likely
penicillin.
diagnosis.
Syphilis.
Syphilis. Third stage.
Is it
Yes,
primary,
yes.
secondary, or tertiary syphilis?
Tertiary.
Secondary.
Secondary syphilis.
This is the secondary syphilis. How can we differentiate among the three, primary, secondary, and tertiary? How to differentiate between the three stages of syphilis? So in case of primary syphilis, there will be the only isolated ulceration. There would be painless ulceration. And whenever there is appearance of the rash, this indicates the secondary syphilis. So there is widespread non-itchy rash. So features of syphilis plus rash, this points towards the secondary syphilis. And there are some other features of the tertiary syphilis, like there may be formation of gomas, ascending aortic aneurysm, tabes dorsalis, Arshil Robertson pupil. So this is a case of secondary syphilis. And how to treat a case of secondary syphilis?
Intramuscular benzathine penicillin.
Yes, we'll be going for the intramuscular long-acting benzathine penicillin G. And the ceftriaxone, this is usually used for the management of gonorrhea, both uncomplicated and complicated gonorrhea. Regarding doxycycline, doxycycline can be given in a patient with syphilis if the patient is penicillin allergic. And also for doxycycline, we need to go for the 2 weeks treatment, either 500 milligram twice daily or 100 milligram once daily. And fluconazole, this is indicated for the fungal infection. And regarding acyclovir, this is the antiviral medication. This is usually indicated for the herpes simplex virus infection or varicella zoster virus infection. The most appropriate treatment for secondary syphilis is the intramuscular injection of the benzathine penicillin G. Syphilis caused by Treponema pallidum respond well to this antibiotic regimen, which can effectively eradicate the infection at all stages. Early treatment can prevent complications such as neurosyphilis or cardiovascular syphilis that can occur if left untreated. Additionally, treating syphilis reduces the risk of transmission to the sexual partners. And also in the original scenario, the patient also had the rash, and after a few weeks, the patient developed the maculopapular rash on the soles and the feet, and there was also presence of the lymphadenopathy, and the diagnosis was the secondary syphilis. In the original scenario, they asked regarding the diagnosis. Diagnosis was the secondary syphilis.
A 38-year-old woman with a known diagnosis of hypertrophic obstructive cardiomyopathy is seen in the cardiology clinic for routine follow-up. She has experienced occasional palpitations and shortness of breath on exertion. Echo reveals marked left ventricular hypertrophy and an enlarged left atrium. Her blood pressure is 125/80 and her heart rate is 88 and regular. What does the enlarged left atrium most likely indicate in this patient? Increased risk of atrial fibrillation, increased risk of heart failure with preserved ejection fraction, increased risk of mitral regurgitation, increased risk of pulmonary hypertension, or increased risk of sudden cardiac death.
So implication or sequelae of the left atrial enlargement in case of HOCM. So what should be the implication?
Increased risk of AF.
Yes, very good. There would be increased risk of the atrial fibrillation. So an enlarged left atrium in a patient with HCM, it will primarily indicate the increased risk of the atrial fibrillation, usually due to the increased atrial pressure as well as the volume overload. So in case of HCM, there would be involvement of the left ventricular hypertrophy, and this LVH, it will obstruct the left ventricular outflow during the systole. And this obstruction, it will lead to the elevated left ventricular filling pressure, and over the time the increased pressure from the left ventricle, this is transmitted backward towards the left atrium, causing the left atrial dilatation. And the enlarged left atrium, it will create a substrate for the atrial arrhythmias, particularly the atrial fibrillation. And whenever there is formation of atrial fibrillation in a patient with HCM, this is usually due to the loss of the atrial contraction, which will reduces the cardiac output. Since the steep left ventricle, this is more dependent on atrial contraction for the filling, and this increased risk of atrial fibrillation, it will also increases the risk of thromboembolism as well as the stroke. And with respect to the other options, so increased risk of heart failure with the preserved ejection fraction. So this is due to the diastolic dysfunction. And increased risk of mitral regurgitation, so it can occur in a patient with HCM due to the SAM, meaning the systolic anterior motion of the mitral valve. Increased risk of pulmonary hypertension, so pulmonary hypertension, it can occur secondary to left-sided heart disease, but this is not the primary concern related to the left atrial enlargement. And with respect to the increased risk of the sudden cardiac death, so SCD in HCM, this is related to the arrhythmias like either ventricular tachycardia or ventricular fibrillation. So there will be increased risk of atrial fibrillation. An enlarged left atrium in a patient with HCM is a significant risk factor for developing atrial fibrillation. Atrial fibrillation exacerbates symptoms of HCM and increases the risk of thromboembolic events, including the stroke. Patients with HCM and atrial fibrillation should be considered for anticoagulation therapy. To mitigate this risk, regular monitoring and early intervention for AF can improve outcome in this patient. While an enlarged left atrium can be seen in a patient with heart failure with a preserved ejection fraction, this is not the primary concern in a patient with HCM. And this preserved ejection fraction heart failure, this is more commonly seen in conditions such as hypertension and diabetes. So this is usually a result of diastolic dysfunction. An increased risk of mitral regurgitation, it can occur due to the SAM, systolic anterior motion of the mitral valve. Pulmonary hypertension can develop secondary to chronic left atrial pressure elevation. However, in the context of HCM, enlargement of left atrium, this is more indicative of an increased risk of atrial fibrillation rather than directly causing the pulmonary hypertension. And the SCD is related to ventricular arrhythmias like either ventricular tachycardia or ventricular fibrillation. And in the original scenario, it was a little bit different. So it was a scenario of HCM, and there's which parameter is associated with the increased risk of the SCD. So interventricular septum diameter 3.3 centimeter, enlarged left atrium, outflow gradient of 30, and there is a septal anterior motion of the mitral valve leaflet. Based on the ESC guideline on the HCM, so whenever there is extreme left ventricular hypertrophy, usually greater or equivalent to 30 millimeter or greater or equivalent to 3 centimeter, this is validated as a SCD risk factor. So whenever the septal thickness is greater or equal to 30 millimeter, this is strongly associated with the ventricular arrhythmia due to either myocardial ischemia or other factors. So it will usually increases the highest risk of the SCD, especially either ventricular tachycardia or ventricular fibrillation. So in case of HOCM, whenever the intraventricular septum diameter is greater or equal to 30 millimeter, it will carry the highest risk of SCD. Okay.
A 32-year-old woman is referred to the respiratory clinic with a history of recurrent respiratory infections and chronic cough. She is a non-smoker and has no significant past medical history. Her chest X-ray shows diffuse interstitial infiltrates. A bronchoalveolar level is performed and the sample is analyzed for cellular composition and surfactant levels. What cell type is responsible for the production of lung surfactant? Goblet cell, macrophage, neutrophil, type 1 pneumocyte, or type 2 pneumocyte?
Type 2 pneumonia.
Yes, the
Type
type
2
2
pneumocyte.
pneumocyte, also known as the type 2 alveolar cell. These are responsible for secreting the surfactant in the lungs. And the type 1 pneumocyte, they are usually responsible for the gas exchange. So what is the component of main constituent or main component of pulmonary surfactant?
Phospholipid.
This is the DPCC, dipalmityl phosphatidylcholine. DPCC is the main constituent. So the type 2 alveolar cell or type 2 pneumocyte, these are usually the cells found in the alveoli of the lungs, and they produce and secrete the pulmonary surfactant. And this surfactant is usually the lipoprotein complex that usually reduces the surface tension in the alveoli, which will prevent the lung collapse, and it will also helps in the gaseous exchange. And type 1 pneumocyte or type 1 alveolar cell, so they are mainly responsible for the gaseous exchange. This type 1, they usually do not secrete the surfactant, and this surfactant, they will also plays a crucial role preventing the respiratory distress and lung collapse, especially in the premature infant who usually lacks the adequate surfactant. Type 2 pneumocyte are the primary cells responsible for producing surfactant in the lungs. Surfactant is essential for reducing the surface tension within the alveoli, preventing alveolar collapse, meaning atelectasis, ensuring the efficient gas exchange. This function becomes critical in conditions such as ARDS, where the surfactant production may be impaired. Type 2 pneumocyte also plays a role in alveolar repair, making them vital for maintaining lung function. Without sufficient surfactant, the alveoli can't expand properly, leading to decreased oxygenation, which aligns with the patient's presentation of cyanosis and the respiratory distress. Goblet cells are the specialized epithelial cells found in the airways, where they secrete mucus to trap particles and the pathogens. A neutrophil or a type of the white blood cell that participates in the body's defense against infection, especially the bacterial infection. While they are involved in inflammatory response within the lungs during infections, they do not produce the surfactant. And type 1 pneumocyte, they are involved in the gas exchange.
A 32-year-old obese woman presents to the emergency department with complaints of headaches and double vision. On examination, she has a left cranial nerve 6 palsy. Fundoscopy reveals bilateral papilloedema. What is the most likely diagnosis? Brain tumor, diabetic retinopathy, idiopathic intracranial hypertension, multiple sclerosis, or stroke?
Idiopathic
C.
intracranial.
Idiopathic.
C.
So this is a case of IIH, idiopathic intracranial hypertension. So this is most commonly seen in the young female with or without history of taking some of the drugs like the tetracycline, and there would be history of the chronic postural headache with morning worsening, which is often worsened when the patients lie flat or strain when using toilet. And there will also be history of sudden worsening of the headache, and there would be bilateral 6-nerve palsy, meaning the abducens nerve palsy. So in some of the scenario, they will directly mention the patient is having the abducens nerve palsy, or in other scenario, they may give some of the examples of abducens nerve palsy like the adductor palsy, and there may also be bilateral papilloedema, hypertension with the elevated D dimer, and diagnosis would be idiopathic intracranial hypertension. And whenever idiopathic intracranial hypertension is suspected, the next step of investigation would be the MR phenogram, magnetic resonance phenogram, to exclude the CVST, cerebral venous sinus thrombosis, as the treatment protocol is completely different. So whenever CVST or IIH is suspected, the immediate next step would be MR phenogram. And if they asked what should be the initial therapeutic intervention, then only in that case you can go for the lumbar puncture with the pressure measurement. But whenever they just mention what should be the next investigation, then go for the MR phenogram. And regarding management, we can go for the weight reduction as well as the acetazolamide. So which one is the first line management? Which one is the mainstay of the management with respect to idiopathic?
Acetazolamide, the first step.
Weight reduction.
So which one is the mainstay of management?
Weight reduction.
So weight reduction would be the mainstay of the management. And what should be the first line management, first line treatment?
Acetazolamide.
Yes, you will be going
Lumbar
for
puncture.
the acetazolamide. And with respect to the lumbar puncture, so lumbar puncture with or without pressure measurement. So this is either second line treatment or this is first line therapeutic intervention. So these three things is very important. Weight reduction is the mainstay of the treatment. Acetazolamide is the first line treatment. Lumbar puncture with or without pressure measurement, this is either second line treatment or this is the first line therapeutic intervention. So obese young female with the chronic postural headache or blurring of vision, think of the idiopathic intracranial hypertension, and one of the most common agent implicating is the tetracycline. So in some cases they may directly mention tetracycline, or in some of the scenario they will give a scenario of the either acne or some other condition that are treated with the tetracycline. And investigation would be the MR phenogram, and first line treatment would be IV acetazolamide, and second line would be lumbar puncture. And whenever you find postural headache with normal imaging, think of the idiopathic intracranial hypertension.
Sir, I have a question.
Yes, please go on.
Sir, if there's a scenario where it says what's the next step, and we have all the options available, if there's lumbar puncture, acetazolamide, or weight reduction, what should we go for?
So it will depend on the scenario. From the scenario, if you find this is the definitive case of IIH, then in that case the next step would be acetazolamide. And if you think it can be either CVST, cerebral venous sinus thrombosis, or it can be idiopathic intracranial hypertension, then the next step would be to go for the MR venogram. So depending on the scenario, you will decide whether you should go for acetazolamide or you will at first go for the MR venogram to exclude the cerebral venous sinus thrombosis. Idiopathic intracranial hypertension, also known as the pseudotumor cerebri. This is characterized by increased intracranial pressure without an obvious cause found in neuroimaging or other investigation. It commonly occurs in young obese women and presents with the symptoms such as headache, visual disturbance, including diplopia due to cranial sixth nerve palsy, papilloedema on the fundoscopy. The condition can present to progressive visual loss if not managed promptly. While brain tumor can present with headache, cranial nerve pulses due to mass effect or increased intracranial pressure, they are usually accompanied by the focal neurological deficit that localize to specific areas of the brain depending on the tumor's location. Neuroimaging would typically reveal an identifiable mass lesion. And diabetic retinopathy, this is usually seen as a part of long-standing diabetes mellitus affecting the retinal vessel. And in case of multiple sclerosis, there will be features of optic neuritis. And also in case of stroke, there will be features of the FND, focal neurological deficit, specifically either hemiparesis or hemiplegia or aphasia. So in the original scenario, the patient presenting with headache, diplopia, papilloedema, tinnitus, and instead of directly mentioning the sixth nerve palsy, they mentioned the adductor palsy. And the patient was obese. The BMI was 32 and the diagnosis was the IIH. So headache, diplopia, papilloedema, these are usually the classic presentation. And the tinnitus usually refers to the pulsatile tinnitus, synchronizing with the heartbeat. And the adductor palsy, it indicates the involvement of the sixth cranial nerve, meaning the abducens nerve, which is commonly affected in case of IIH due to increased intracranial pressure causing stressing of the nerve.
A 62-year-old man presents to the emergency department with sudden onset of left-sided weakness and slurred speech. He has a past medical history of hypertension and hyperlipidemia. His medications include lisinopril, atorvastatin, and clopidogrel. What's the mechanism of action of clopidogrel?
C.
Yeah. C. Cyclooxygenase inhibition, glycoprotein 2b3 receptor antagonism, inhibition of adenosine diphosphate mediated platelet aggregation, vitamin K antagonism, or adenocyte reuptake inhibition.
So mode of action of clopidogrel or prasugrel. Inhibition of
PY12
PY12
inhibitors.
So these are the P2Y12 inhibitor. These are also known as the platelet ADP, adenosine diphosphate mediated platelet receptor inhibitor, or they causes ADP mediated platelet aggregation. This is the mode of action of clopidogrel and ticagrelor. And there is another groups of drug, abciximab, tirofiban, and the eptafavitide. They are the glycoprotein 2b3a inhibitors. And dipyridamole is the adenosine uptake inhibitor. And in every diet, you will get at least one question from this chart. So either ADP receptor inhibitor will come or glycoprotein 2b3a inhibitor will come. or the adenosine uptake inhibitor will come. And in most of the cases, clopidogrel, this one is the most important, this one is the second most important. So clopidogrel is the ADP receptor inhibitor, meaning inhibition of adenosine diphosphate mediated platelet aggregation. Which one is cyclooxygenase inhibitor? Which drug is
NSAIDs.
cyclooxygenase inhibitor? These are the NSAIDs. These NSAIDs are the cyclooxygenase inhibitors. And glycoprotein 2B3A inhibitors. Examples, recall the name. Glycoprotein 2B3A inhibitors. What are the drugs? Tyrofibin, epsiximab, and the
Abscizumab,
eptafabitide.
efotibide.
Hepatitis.
Epsiximab. Sorry. So you must remember the three drugs: epsiximab, tyrofibin, eptafabitide. These are the glycoprotein 2B, 3A glycoprotein inhibitors. And dipyridamole is the adenosine uptake inhibitors. This is also the phosphodiesterase inhibitors. And dipyridamole, it enhances the effect. There was a mnemonic. It enhances the effect of most probably the. Can anyone recall regarding dipyridamole? It enhances the effect of one thing and it causes reduction of another thing. What was the mnemonic? I can't recall. Okay, you can go to
Aminophylline.
the past medicine Pearl notes. You'll find there.
It's
Aminophylline,
DEAR.
Aminophylline.
And vitamin K antagonism. This is the warfarin. Warfarin, it works by inhibiting the synthesis of the vitamin K dependent clotting factors 2, 7, 9, 10, or you can remember as 1972. And this vitamin K dependent clotting factors, these are essential for the coagulation cascade. Clopidogrel is a prodrug that requires hepatic conversion to its active metabolites. It selectively and irreversibly inhibits the P2Y12 components of the ADP receptor on the platelet surface. This inhibition prevents ADP-mediated activation of glycoprotein 2B, 3A complex, thereby inhibiting platelet aggregation and reducing the risk of thrombotic events. And COX inhibition are the NSAIDs, especially the aspirin. Which drug is COX-2 inhibitors? COX-2 inhibitors?
The coxibs.
Yes, the iterocoxib or the valdecoxib, something like this. And glycoprotein 2B, 3A, epsiximab, eptafabitide, tyrofibin. And vitamin K is the warfarin, 2790 or 1972. And adenosine uptake inhibitor is the dipyridamole. Dipyridamole works by increasing the concentration of adenosine, a potent vasodilator, and inhibition of platelet aggregation. It also has a second mechanism of action. It inhibits the phosphodiesterase that breaks down the cyclic adenosine monophosphate.
A 42-year-old man presents to the emergency department with a history of a rash that began as a small red spots on his arms and has now spread to his trunk and legs. On examination, he has target lesions with central clearing, consistent with erythema multiforme. He mentions a recent hiking trip where he was bitten by multiple insects. He has no known drug allergies and no significant past medical history. What is the most appropriate management? Acyclovir, doxycycline, hydrocortisone cream, prednisolone, or topical antibiotics?
Doxycycline.
Doxycycline. This is Lyme's disease.
Lyme.
So this is a case of Lyme disease, And first line management for Lyme disease is the doxycycline. And what should be the management in a pregnant lady with the Lyme disease?
Erythromycin. Erythromycin.
Not not
Ceftriaxone.
erythromycin. We need to
Azithro.
go for the amoxicillin, okay? We need to go for the amoxicillin. So first line for early disease, go for doxycycline. If the patient is pregnant, go for amoxicillin. If there is a disseminated disease, then go for the ceftriaxone. And the late features means there would be involvement of heart or involvement of brain. And involvement of heart can be either heart block or myocarditis. And brain involvement would be bilateral facial nerve pulses. So always remember, there would be bilateral, not unilateral. The advanced stages of Lyme disease, they will come up with the bilateral facial nerve palsy, or there may be features of meningitis. And bullseye is the early features. And this is caused by the Borrelia burgdorferi, bite by ticks. Organism is the since this is caused by Borrelia burgdorferi, this is also known as the borreliosis. And in most of the cases, there will be history of travel to the Alps, especially the Austrian Alps. And patient will have facial nerve palsy, relative bradycardia, small joint, polyarthritis. And this Borrelia burgdorferi, this is the spirochaetal organism. Doxycycline is the most appropriate management in this case, particularly given the context of a recent hiking trip and insect bite. The clinical presentation of erythema multiforme in this context raises the suspicion for Lyme disease, which is transmitted by tick bite. Doxycycline is the treatment of choice for Lyme disease, and this effective in treating bacterial infection, including the Borrelia burgdorferi. And acyclovir, this is antiviral medication. It can be used for the herpes simplex virus infection. And hydrocortisone cream, this is the topical steroid. This is it can be used for the topical management related to the dermatitis. And in the original scenario, it was a little bit complicated with respect to either it was a Lyme disease or it was the granuloma annulare. So let me show you. So the patient had a history of return from the US, presented with the 10 centimeter annulus erythematous lesion on the forearm. And they asked regarding the diagnosis whether this is Lyme disease or it was the granuloma annulare. So in case of granuloma annulare, usually it will present like a ring-like or skin-colored or erythematous lesion, often with the slightly raised border. And this granuloma annulare, this is not related to the recent history of travel as well as the distinct bullseye appearance. And the bullseye appearance, this is the pathognomonic features of Lyme disease. So a classic skin manifestation is the erythema migrans, which presents as an expanding annular erythematous lesion with the center clearing, often referred to as bullseye appearance, and also the travel history. This is more suggestive of the Lyme disease.
A new bedside test for detecting coronavirus is being developed. During the trial phase, the test is evaluated on 5,000 individuals. Of these, 50 tested positive using the bedside test and 60 were confirmed positive by PCR testing. Among the 4,950 individuals who tested negative with the bedside test, all but 10 were confirmed negative by PCR testing. What is the sensitivity of these new bedside tests compared with coronavirus disease 2019 PCR testing? 90%, 92%, 95%, 85%.
So how to calculate the sensitivity formula? How to calculate sensitivity?
True positive
True
divided by
positive,
true positive plus false
false
negative.
So
positive.
true
False
positive
positive.
divided by. So this is the
True
test
positive.
ability to correctly identify individuals who actually have the disease. So true positive divided by true positive plus false negative, and when expressed in percentage, multiply by 100. So true positive means people who test positive by the bedside test and are confirmed positive by the gold standard PCR. And false negative means the people who test negative by the bedside test but are actually positive by the PCR. And from the scenario, this information is extracted. So the total individual tested was 5,000. Confirmed positive by PCR, meaning gold standard was considered as PCR was 60. Tested positive by bedside test was 50. Tested negative by bedside test was 4950. So the true positive was given by as 50. Now we need to calculate the false negative. So false negative means confirmed positive by PCR minus true positive. So true positive was 50, confirmed positive by PCR was 60, so false negative is 10. So if we now apply the formula, so true positive 50 divided by true positive plus false negative, so answer was 83%. So it was the 83%.
So isn't true positive 60 here?
No. True positive here is 50, not 60. True positive here is 50. Okay, it's not 60. Is
But
the
60
total
was
confirmed positive. 60 is the total confirmed positive by PCR as 60. But the true positive means the individuals are tested positive by the bedside test and also confirmed positive by the PCR. So this is the true positive. This was 50.
So as they are asking sensitivity for PCR, so in PCR there were 60 positive cases, no?
yeah, exactly. So 60 were confirmed positive by PCR. So true positive should be 60, isn't it?
So among the 4950 individuals who had out of 50 tested positive using the bedside. No. This is the true positive. This is the true positive, and this is the total confirmed positive by the PCR. And total confirmed testing minus true positive. This means 10 is the false negative. So 50 divided by 50 plus 10 is equal to 83%. Okay, next.
A 28-year-old woman presents to the emergency department with a 3-month history of intermittent abdominal pain, diarrhea with urgency, and unintentional weight loss. She also reports experiencing fatigue and occasional fevers. On physical examination, she has right lower quadrant tenderness, but no palpable mass. Blood tests reveal anemia and elevated inflammatory marker levels. What is the most appropriate next investigation to confirm the most likely diagnosis? Abdominal ultrasound, capsule endoscopy, colonoscopy with biopsy, CT angiography, or stool culture?
So most likely diagnosis. What may be the
IBS.
most likely diagnosis in this patient?
Crohn's disease.
Yes, the most likely diagnosis is the Crohn's disease. So what should be the most appropriate next investigation to confirm Crohn's disease?
Colonoscopy with
Colonoscopy
biopsy.
with
Yes, we
biopsy.
need to go for the colonoscopy with biopsy. So this patient has comes up with the intermittent abdominal pain, diarrhea associated with urgency. There is also features of fatigue as well as the weight loss. And this right lower quadrant tenderness, this usually possibly suggests the terminal ileum involvement, which is one of the commonest site for Crohn's disease. And with respect to the investigation, anemia can be explained by chronic inflammation or as a part of malabsorption of either iron or vitamin B12. And there is also elevated inflammatory marker, which is more consistent with the Crohn's disease rather than the ulcerative colitis. And usually in case of Crohn's disease, the terminal ileum, it can affect any parts of the GI tract, but usually the terminal ileum, this is the most common site for the Crohn's disease. And this colonoscopy with biopsy, this is the gold standard investigation for the Crohn's disease. This colonoscopy, it will allows for the direct visualization of the mucosa, and it can detect the ulcer or cobblestone appearance as well as the strictures. And this histological confirmation, meaning the biopsy, it will reveals the non-caseating granuloma, which is one of the hallmark components of Crohn's disease. And on biopsy, you can also get the features of chronic inflammation involving all the layers of the bowel wall, meaning the transmural involvement. And also with the colonoscopy with the colonoscopy, you can also go for the evaluation of the terminal ileum as well as the colon. So this abdominal ultrasound, it can identify the complication related to Crohn's disease like the abscess or fistula, but it cannot confirm the diagnosis of Crohn's disease. And capsule endoscopy, this is useful in evaluating the small bowel disease, especially the angiodysplasia, which is seen in case of Hayes syndrome. CT enterography, so this is usually used for the assessment of the small bowel involvement as well as the complication. And this CT enterography, it will not provide the histological confirmation. And stool culture, this is useful for ruling out the infectious causes of diarrhea. So the gold standard investigation to confirm the diagnosis would be the colonoscopy with the histological confirmation with the biopsy. Colonoscopy with biopsy remains the gold standard for diagnosing Crohn's disease, as it allows direct visualization of the mucosal abnormalities such as ulcers, strictures, or cobblestoning typical of the Crohn's disease, and enables histological confirmation from biopsy showing features such as the non-caseating granuloma. And abdominal ultrasound, this is for complication like abscess or fistula. Capsule endoscopy for visualizing the small intestine. And the capsule may causes the capsule retention in a patient with strictures. And stool culture are essential to rule out the infectious causes of diarrhea.
A 78-year-old woman presents the general practitioner with her daughter, who is concerned about her mother's increasing difficulty in managing daily activities following a recent stroke. The patient has significant mobility issues and requires assistance with personal care tasks such as bathing and dressing. What is the most appropriate use of the Barthel Index in this patient? Assessing cognitive function, evaluating depression severity, measuring functional independence, screening for falls, or tracking disease progression.
C. Functional independence.
So assessment
C.
of Barthel Index in a patient with stroke. This is for the measurement of the functional independence. This is related to ADLS, activities of the daily living. So this Berthel index, this is specifically designed to measure the patient's level of the functional independence, particularly in performing the ADLS, activities of the daily living. And this Berthel index, it assesses the 10 domains. So regarding the 10 domains, you can remember using the mnemonic, the FB, GROOM, PDT, and the M. So FB, so F for feeding, B for bathing. FB, the Facebook, F for feeding, B for bathing. And groom means grooming. And with respect to BDT, B means bowel control, B means bladder control, D for dressing, T for toilet, and T for transfer from bed to chair. And last M for the mobility, either on the level surface or on the stairs. So FB, Facebook, groom, BDT, and the M. And assessment of cognitive function. So how to assess cognitive function? How to
MMSE.
assess? Yes, you can go for the MMSE, or you can go for the MOCA. You can either go for MMSE, mini mental state examination, or you can go for the Montreal cognitive assessment. So can anyone tell me the scoring based on the MMSE? Mild, moderate, severe, mild cognitive impairment. What should be the MMSE score?
19 to 23, and 10 to 18 moderate, and less than 10 or 9 severe.
So this is also known as the Falstein test. And normal cognition, usually the score, the total score is 30. This points towards the 30-point questionnaire. So whenever the score is greater or equal to 24, this is regarded as normal cognition. And severe cognitive impairment, less than or equivalent to 9. Moderate means 10 to 18, mild means 19 to 23, or simply you can remember less than 10 is severe, and severe means the NMDA receptor would be applied like the memantine. And mild to moderate means 10 to 20 roughly, and whenever 10 to 20, the acetylcholinesterase would be applied like the donepezil, rivastigmine, or galantamine, provided there is no contraindication. So whenever the score is less than 10, go directly for the NMDA receptor antagonist like the memantine. The Berthel index is specifically designed to measure a patient's level of functional independence, particularly in performing activities of daily living, ADLS. It assesses the 10 domains. So Facebook, FB, groom, then B, DT, and last one is the M. And for the cognitive assessment, you can go for MMSE, also known as Falstein test, or you can go for the Montreal cognitive assessment. And depression severity, there is either a big depression inventory or geriatric depression scale.
A 51-year-old woman presents to the emergency department with a 2-week history of malaise, fatigue, and reduced urine output. She reports taking a new antibiotic for an upper respiratory tract infection 3 weeks ago. On examination, she has mild bilateral flank pain and her blood pressure is 145/95. Lab investigations reveal elevated serum creatinine levels, and her full blood count demonstrates eosinophilia. What is the most appropriate management for this patient? Discontinue the offending drug, initiate hemodialysis immediately, prescribe high-dose corticosteroids, refer for urgent renal biopsy, start antihypertensive therapy.
So most likely diagnosis.
Interstitial nephritis.
Interstitial nephritis.
So this is the acute interstitial nephritis. So what are the drugs that commonly leads to acute interstitial nephritis?
NSAIDs.
PPI, NSAIDs, penicillin, cephalosporin, and acyclovir.
Yes, very good. Acute interstitial nephritis. And how? What should be the first line management in AIN or first step?
Stop
Discontinuation of
blockading drug.
offending drugs. So usually the NSAIDs, PPI, penicillin, cephalosporin, acyclovir. They usually list to the acute interstitial nephritis. And acyclovir, it can also lead to the crystal urea. And this eosinophilia, this is the cardinal features or hallmark features. There would be either eosinophilia or eosinophiluria, and there will be deterioration in the creatinine or reduced urine output. And on dipstick urine, there would be presence of RBC, WBC, and the proteins. So this eosinophilia, this is one of the cardinal features. And what should be the biopsy findings in case of acute interstitial nephritis? Biopsy findings. What should be the biopsy findings? There would be T lymphocyte and monocyte infiltration. How to differentiate ATN from AIN? Acute interstitial nephritis from acute tubular nephritis. Differentiating point.
ATN will have red cell cast.
Yes, ATN will have the red cell cast.
And urine sodium should be more than 40.
Yes, the urinary sodium should always be greater than 40. Sterile pyuria with eosinophilia, white cell cast in the setting of rash and fever should raise the suspicion of acute interstitial nephritis, which is commonly due to the antibiotic therapy. So penicillin, cephalosporin, NSAIDs, PPI, allopurinol, furosemide, diuretics, and the rifampicin. Another one is the acyclovir. But always remember the 4 drugs: PPI, NSAID, acyclovir, and the antibiotics. Most commonly the penicillin and the cephalosporin. So AIN will have the white cell cast, ATN will have the granular cast. So fever, rash, eosinophilia, sterile pyuria, and the white cell cast. And the management should be discontinuation of the offending drugs. So acute interstitial nephritis is inflammation of the renal tubulointerstitium secondary to hypersensitivity reaction to drugs. The most common drug-related cause is the NSAIDs. Rapid onset of renal failure coupled with rash and eosinophilia as a result of exposure to NSAIDs or amoxicillin is highly suspicious of a diagnosis of interstitial nephritis. And eosinophilia is common. Eosinophiluria is the pathognomonic, and the classic presentation would be fever, maculopapular rash, and the arthralgia. And the mainstay of the treatment is the cessation of the causative agent. In some cases, to hasten the delivery, you can also go for the high dose prednisolone. And in the renal biopsy, there would be infiltration of the mononuclear cells, especially the T lymphocyte. Underlying diagnosis here is the acute interstitial nephritis. When it is suspected to be drug induced, the most appropriate management is to discontinue the offending drugs. In many cases, stopping the causative medication can lead to significant improvement in the renal function without further intervention. Continuing use of the implicated drug may exacerbate the renal damage. Hemodialysis might be necessary if there are signs of severe kidney failure, such as hyperkalemia or fluid overload that cannot be managed conservatively. Okay, next.
A 77-year-old woman presents to her general practitioner with worsening rigidity and bradykinesia over the past 6 months. She has a known diagnosis of Parkinson's disease, which was diagnosed 3 years ago. Her current medications include levodopa, carbidopa, and pramipexole, but she reports that these are no longer as effective as they once were. She denies any new symptoms such as hallucinations or significant changes in mood. What is the most appropriate next management for this patient? Add amantadine, increase the dose of pramipexole, induce entacapone, switch to deep brain stimulation, or switch to rasagiline.
So Parkinson's disease patient not responding well to levodopa carbidopa combination and the pramipexole. So most appropriate next step in the management.
Introduce entacapone.
Yes, we can introduce the entacapone. Mode of action of entacapone.
COMT.
This is the COMT inhibitor, catechol or methyltransferase inhibitor. So this patient has the Parkinson's disease with worsening rigidity and bradykinesia despite being on levodopa carbidopa combination as well as the pramipexole. So this levodopa carbidopa, this is the cornerstone of the Parkinson's disease management, and pramipexole is the dopamine agonist. And the patient has reported decreased effectiveness of her current regimen, likely due to the wearing off phenomenon. So the wearing off phenomenon, it usually occurs in Parkinson's disease as the disease progresses and the duration of levodopa's effects, it becomes shorter, leading to the resurgence of the motor symptoms before the next dose. So this entacapone, this is the catechol O methyltransferase. It has three general additive effect or beneficial effect. It will reduces the peripheral breakdown of levodopa. It will prolong the levodopa's half-life as well as the availability in the brain, and it will also enhances the duration of the symptoms control. So regarding targeting the wearing off effect, the COMT inhibitor, they are particularly effective for managing the motor fluctuation. Motor meaning the rigidity as well as the bradykinesia. And since the patient is denying hallucination or mood changes, so that means she can tolerate the additional dopaminergic effect without the significant risk of psychiatric complications. So we can introduce entacapone. And regarding amantadine, this is primarily used for treating the dyskinesia associated with the long-term levodopa use. And increasing the dose of pramipexole. So if we increases the dose, there may be some side effect like the impulse control disorder leading to gambling or hypersexuality, or there may be increased somnolence, or in some cases increased hallucination leading to the Lewy body dementia. And switch to the deep brain stimulation. This is usually indicated for patients with the advanced Parkinson's disease or whenever there is severe motor fluctuation or dyskinesia refractory to the medical therapy. And the last one, rasagiline. What is the mode of action? Rasagiline.
MAO-B.
This is the MAO-B inhibitor, monoamine oxidase B inhibitor. So it can reduces the motor symptoms in early Parkinson's disease, but regarding the wearing off effect, the COMT inhibitor, they are more suitable. Introducing entacapone is the most appropriate management in this scenario because it is a catechol O-methyl transferase inhibitor that can help to prolong the effect of levodopa by inhibiting its peripheral degradation. It can be particularly useful when patient experiences wearing off phenomenon where their current medication regimen become less effective over time. By extending the duration of action of levodopa, entacapone can help to manage the symptoms more consistently throughout the day, hence addressing the issues of rigidity and bradykinesia more effectively.
A 35-year-old woman presents to the emergency department with complaints of headache with confusion, multiple petechiae, and prolonged bleeding from minor cuts over the past month. She has a low hemoglobin level and a significantly reduced platelet count and splenomegaly. She has no history of trauma or anticoagulant use. What is the most likely diagnosis? Acute myeloid leukemia, aplastic anemia, idiopathic thrombocytopenic purpura, sickle cell anemia, or thrombotic thrombocytopenic purpura.
So most likely diagnosis,
TTP.
ITP.
TTP.
TT
AML.
so what are the pentads of TTP? TTP pentad.
Fever, confusion, renal failure, um, thrombocytopenia, rash. Rash?
Is it rash? No, not rash.
No, not
Hemolytic
rash.
anemia.
neurological symptoms
Eh,
and anemia.
Anemia.
Hemolytic anemia.
Hemolytic anemia.
So there would be fever, neurological sign, most commonly the stroke-like features. There would be thrombocytopenia, microangiopathic hemolytic anemia, and the renal failure. So these 5 components would be present. And which feature will differentiate TTP from HUS?
Neuroscience.
Yes,
Neurological.
the presence of neurological signs, they will differentiate, and in most of the cases neurological sign is the features of stroke. And also if you get the features of fever, then also consider TTP rather than HUS. So how to treat a case of TTP? Which one? How to treat a case of TTP? Thrombotic thrombocytopenic purpura. Which one is the first line treatment?
Plasma exchange.
Yes, we'll be going for the plasma exchange. So TTP, P for plasma exchange. If TTP is suspected, the first line treatment of choice is the plasma exchange. Plasma exchange removes any antibodies which inhibits ADAMTS13 whilst also replacing the functional version of the enzyme. And in case of refractory TTP, you can also go for the IV immunoglobulin. So plasma exchange is the first line. So the presence of fever and neurological involvement differentiate TTP from the HUS. And also with respect to the renal impairment, in case of HUS, there would be severe renal impairment. In case of TTP, there is usually mild renal impairment. So features of AKI, acute renal failure, microangiopathic hemolytic anemia, thrombocytopenia, fever, and the neurological symptoms. This is the pentad of TTP. And in case of HUS, you will get the triad. And usually, in case of HUS, there would be also acute renal failure and the microangiopathic hemolytic anemia, but there would be no neurological features. And in case of ITP, there should be isolated thrombocytopenia and all other features would be absent. TTP is characterized by a pentad of thrombocytopenia, microangiopathic hemolytic anemia, neurological symptoms, renal impairment, and fever. This patient's presentation with a low hemoglobin level, low platelet count, splenomegaly, alongside her clinical neurological symptoms and PTG aligns with the TTP. TTP involves widespread microvascular thrombosis, which leads to organic damage, including spleen, resulting in its enlargement. And AML, it can present with pancytopenia, including low platelet count, low hemoglobin count, bone marrow infiltration by the malignant cell from the myeloid series, and aplastic anemia will have the purely pancytopenia, and ITP will have the isolated thrombocytopenia. How to treat a case of ITP? First line treatment,
Oral steroid.
Prednisolone.
so will we go for the oral prednisolone. And other treatment for ITP, alternative, sorry, not alternative, second line or third line, something like this.
IVIG.
Yes. Okay.
So we have the treatment option, oral prednisolone, IV immunoglobulin. We can also go for a splenectomy or immunosuppressant, and steroid is always the first line, oral prednisolone. Human immunoglobulin is an alternative to steroid in treating ITP, particularly if the platelet need to be raised quickly. So IVIG can be given in patients who do not respond to or have contraindication to prednisolone use, or those who require a rapid rise of the platelet, like in a patient prior to having the surgery. And you can also go for the platelet transfusion. Romiflostim, this is a thrombopoietin receptor agonist, which is a third line agent to treat the ITP. So romiflostim is considered in patients who have not responded to first line and second line treatment, or have symptoms of chronic ITP persisting beyond 12 months. And plasma exchange, this is not used in the treatment of ITP, this is used in the treatment of TTP. So plasma exchange or pre-eclamptic toxemia, PE for not pre-eclampsia, P is for plasma exchange, and T means the TTP, thrombotic thrombocytopenic purpura. ITP should always be considered in the presence of symptoms that suggest isolated thrombocytopenia, especially presenting with epistaxis or menorrhagia.
A 37-year-old woman presents to her GP with a painful vesicular rash on the left side of her face. She notes that the rash appeared 2 days ago and is associated with a tingling sensation. She reports that she previously had chickenpox as a child. On examination, the rash is noted to follow the distribution of the trigeminal nerve. What is the most likely diagnosis? Allergic contact dermatitis, herpes simplex virus infection, herpes zoster virus infection, rosacea, varicella zoster virus infection.
Varicella zoster virus infection.
No,
Herpes zoster. Herpes
Herpes
zoster.
zoster.
So unilateral painful vesicular rash plus trigeminal nerve involvement plus history of previous chickenpox and presence of tingling sensation as a prodrome. So this point shows the herpes zoster virus infection. So this patient is having the painful vesicular rash, and this painful vesicular rash, this is one of the predominant features of the herpes zoster, also known as the shingles. And these vesicles, they usually appear after the prodrome of the tingling as well as the pain. And there would be predominant trigeminal nerve distribution. The rash will follows the dermatomal distribution of the trigeminal nerve, which is also one of the classic features of herpes zoster. And this trigeminal nerve, it has got the 3 branches: ophthalmic, maxillary, as well as the mandibular, and the rash will typically appears on one of the branches. and also the history of chickenpox as a child. This is one of the key risk factor for the development of herpes zoster later in the livelihood. And the varicella zoster virus, they usually lies dormant in the sensory ganglia and can reactivate as an herpes zoster even in the elderly or in the immunocompromised. Usually in the elderly or immunocompromised, but it can also occur in the younger healthy individuals. And the tingling sensation, this occur as a part of the preterm preceding the rash. This is one of the well-known prodrome in the herpes zoster, occurring due to the viral reactivation along the specific nerve, specifically the trigeminal nerves, through its one of the 3 branches. Regarding allergic contact dermatitis, so they will usually comes up with the erythematous itchy rash, and in some cases there may be development of the vesicle, but it will not follows the dermatomal pattern. Herpes simplex virus infection, they will comes up with the painful vesicular lesion, and in case of HSP type 1, there is usually involvement of oral mucosa, and in case of HSP2, there is usually involvement of the genital regions, and it usually does not follows the dermatomal pattern. And acne rosacea, this is characterized by the erythematous facial lesion. There would be prominent blood vessel, so there may be a persistent erythema or telangiectasia or papule as well as the pustule. So most likely diagnosis is the herpes zoster virus infection. And this varicella zoster virus infection, they usually causes the chickenpox. So there would be widespread generalized rash, but here the rash is localized, and there is unilateral rash. The patient's presentation of a unilateral painful vesicular rash along with the trigeminal nerve distribution strongly suggests the herpes zoster. This condition occurs due to reactivation of the varicella zoster virus in the individuals who have had the chickenpox previously, consistent with this patient's history and the symptoms. And allergic contact dermatitis, they will present as an erythematous itchy rash that may develop into vesicles or bullae. And HSP, they will come up with the painful vesicular lesion, oral involvement in type 1, genital involvement in type 2. And rosacea, there would be prominent blood vessel, persistent erythema, telangiectasia, papules or pustules. And varicella zoster virus infection, it would be widespread, and it is usually bilateral. It does not follow single dermatomal distribution, and this also affects more commonly the children. And in the original scenario, it was a very complicated scenario, whether to go for the herpes zoster or to go for the herpes simplex. So a 16-year-old woman had pain over her left cheek since 1 week. She has previously 5 episodes, each lasts for 2 weeks. Lesion happened in the same location every time and resolved spontaneously. Each time it was precipitated by tingling sensation. The lesions are a clear clustered vesicle and the erythematous base, and it was very difficult whether this was herpes simplex or herpes zoster, and the most likely diagnosis was the herpes simplex. So usually in case of herpes simplex, there would be recurrent episodes of grouped painful vesicle on an erythematous base, and the tingling and a burning sensation before the appearance of the lesion. It can also occur in case of herpes simplex virus reactivation. And the herpes zoster, they will come up with the specific dermatomal distribution, which is usually unilateral, and this usually typically occurs once, and this is associated with the history of the prior chickenpox. And also there would be severe pain in case of herpes zoster due to the post-herpetic neuralgia.
The 34-year-old woman presents to the emergency department with stridor, tachycardia, and hypotension rapidly after being stung by a wasp. She has a history of asthma, which is well controlled with regular inhaled corticosteroids. On examination, she appears distressed with labored breathing and an audible wheeze with skin erythema. What is the most appropriate management for this patient? Administer IV corticosteroids, administer IM adrenaline, give IV antihistamines, initiate nebulized salbutamol, or provide oxygen via face mask.
B.
Diagnosis?
Anaphylaxis.
Yes, this is
B.
the anaphylaxis. So we need to go for administration of the intramuscular adrenaline. So what should be the dose of adrenaline in this patient?
0.5 ml.
0.5 ml.
1 in 1000.
Yes, 1 in 1000. In case of anaphylaxis, 0.5 milligram of 0.5 ml, 1 in 1000. And how to treat the accidental adrenaline induced ischemia? First line treatment.
Local infiltration of phentolamine.
So local infiltration of phentolamine, this is the first line. Alternative one is the topical nitroglycerin. So remember the dose would be, the route of administration would be topical. Local infiltration of phentolamine or topical nitroglycerin. If both topical options are there, then go for the local infiltration of phentolamine. And sometimes to make the question more complicated, they will give option like IV phentolamine and the topical nitroglycerin. So always remember, you should always avoid the parenteral route like the IV phentolamine. So first priority would be local infiltration of subcutaneous phentolamine. Second priority should be topical nitroglycerin. So if both of them are in the option, go for local infiltration of subcutaneous phentolamine. And if topical nitroglycerin and IV phentolamine, these two are given in the option, then go for the topical nitroglycerin. So local infiltration of subcutaneous phentolamine or topical nitroglycerin, and always avoid the IV phentolamine. Administering intramuscular adrenaline is the most appropriate initial management for this patient presenting with anaphylaxis due to a wasp sting. Adrenaline acts rapidly to reverse the symptoms of anaphylaxis by causing vasoconstriction, reducing edema in the airways, and improving the blood pressure via its alpha-1 adrenergic effects. Additionally, it provides bronchodilation via beta-2 adrenergic actions, which helps in alleviating the bronchospasm seen in the asthmatic patient. Immediate administration can be life-saving and significantly reduce mortality associated with the severe allergic reaction. And administer IV steroid. Corticosteroid can help to reduce the inflammation and prevent the prolonged or biphasic reaction in anaphylaxis. They do not act quickly enough to address the acute life-threatening symptoms such as the hypotension.
A 32-year-old man presents to the GP with a painful red eye and blurred vision. He reports that this is the second episode in 6 months and mentions experiencing chronic lower back pain that improves with exercise but not with rest. Physical examination reveals reduced lumbar spine flexion and tenderness over the sacroiliac joints. What is the most likely diagnosis? Ankylosing spondylitis, Behçet's disease, reactive arthritis, sarcoidosis, or SLE?
Ankylosing.
Ankylosing.
So this is the ankylosing spondylitis and the limited lateral and forward flexion of the lumbar spine. This is the classic description commonly encountered in the MRCP exam. So limited lateral and forward flexion of the lumbar spine is the ankylosing spondylitis unless proven otherwise. Ankylosing spondylitis. So a combination of lower back pain, stiffness, reduced spinal mobility makes ankylosing spondylitis as the most likely diagnosis. And based on the British Society for the Rheumatology guideline, states that the modified newer criteria should be used to diagnose the ankylosing spondylitis. So we have the clinical criteria, we have the radiological criteria. So there are 3 clinical criteria: low back pain, present for more than 3 months, improved by exercise but not relieved by rest, limitation of the lumbar spine motion in both the sagittal and the frontal planes, limitations of the chest expansion relative to normal values for age and the sex. And on radiological criteria is the sacroiliitis on the X-ray. So they will consider it as a definitive ankylosing spondylitis if the radiological criteria is present plus at least 1 clinical criteria. And probable is if 3 clinical criteria are present alone, or if the radiological criterion is present but no clinical criteria are present. And which HLA is commonly associated with the AS, ankylosing spondylitis? HLA, which HLA is commonly seen in ankylosing spondylitis?
B27.
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 All the arthritis, all the seronegative arthritis, they are commonly associated with the HLA B27, especially the ankylosing spondylitis. And with respect to the heritage, in Caucasian 05, in Chinese and Japanese 04, and in Mediterranean 02. But if you face it difficult to remember, just remember HLA B27. And this ankylosing spondylitis, this typically occurs in the young men, associated with the pronounced early morning stiffness and the buttock pain. So there will be typically worse in the morning, gets better with the activity. And HLA B27 antigen, this is present 90% of patients with ankylosing spondylitis and 75% with reactive arthritis. And the earliest radiographic changes in ankylosing spondylitis is usually the sacroiliitis. What is the advanced radiological features of ankylosing spondylitis? What is the advanced radiological features of ankylosing spondylitis?
Bamboo spine.
Yes, there would be a bamboo spine giving rise to the dagger sign. So presence of syndesmophyte and sacroiliitis. These two are the earliest radiological features, and bamboo spine is the advanced radiological features. So sacroiliitis and syndesmophyte, these are the earliest radiological features, and bamboo spine, meaning there would be single central radiodense line related to ossification of the supraspinous and intraspinous ligament, giving rise to the dagger sign. Diagnosis of ankylosing spondylitis can be best supported by sacroiliitis on the pelvic X-ray. There would be fusion of the bilateral sacroiliac joint. And what should be the presentation in Behçet's disease? Triad, which triad would be present?
Oral also
Oral
genital.
Oral and
Yes, they will come up with the
Genital.
oculo-oral genital manifestation, usually coming up from the Mediterranean heritage. And which HL is related to Behçet's?
HLA-B51.
T2.
HLA-B51. Behçet's is related to HLA-B51, and Takayasu arteritis is related to HLA-B52. And how to treat a case of Behçet's disease? First line and second line.
Low molecular weight heparin.
No, why should not
Mm.
low molecular weight heparin? Low
Thromboembolic.
molecular weight heparin is for
Steroid.
the DVT treatment.
Steroid.
You should go for the steroid. First line would be steroid. If there is no response to steroid, go for the steroid sparing azathioprine. So first line would be prednisolone. Second line would be azathioprine. Ankylosing spondylitis is a chronic inflammatory disease that primarily affects the axial skeleton, leading to progressive stiffness and pain in the spine and the sacroiliac joints. Acute anterior uveitis, also known as the idiitis, is one of its common extraarticular manifestation, occurring in up to 30% of patients with ankylosing spondylitis. The patient's symptoms of chronic lower back pain improving with exercise but not with the rest are classic for the ankylosing spondylitis. Reduced lumbar flexion and sacroiliac joint tenderness on examination further support this diagnosis. While Behçet's disease can present with recurrent anterior and posterior uveitis, it typically involves oral and the genital ulcer as well as the skin lesion such as erythema nodosum or acneiform eruption. The absence of this hallmark mucocutaneous findings makes this diagnosis less likely in this patient. Reactive arthritis can present with conjunctivitis, episcleritis, and anterior uveitis. However, it usually follows an infection such as GI or genitourinary infection within weeks before the onset of symptoms such as arthritis, urethritis, or surfacitis, along with the enthesopathy, which are not reported by this patient. And sarcoidosis, this is usually seen in the Caribbean heritage patient. They may come up with the multisystem granulomatous involvement, including pulmonary involvement, meaning the bilateral hilar lymphadenopathy. And there may be features of hypercalcemia. And easily there will be multisystemic involvement.
58-year-old man is seen in the oncology clinic with worsening lower urinary tract symptoms and lower back pain. He has a history of prostate cancer diagnosed 6 months ago. His recent PSA levels have increased significantly, and he has been started on goserelin therapy. What is the mechanism of action of goserelin? Androgen receptor antagonist, gonadotropin releasing hormone agonist, inhibition of aromatase, inhibition of 5-alpha reductase, selective estrogen receptor modulator.
Gonadotropin releasing hormone B.
So the mode of action of goserelin is the luteinizing hormone releasing hormone analog, or this is the gonadotropin releasing hormone analog, goserelin. So this is the either luteinizing hormone releasing hormone analog or the gonadotropin releasing hormone agonist. And tamoxifen, raloxifen, these are the selective estrogen receptor modulator. And we have the ARP, androgen receptor blockers or androgen receptor antagonist. It can be steroidal, it can be non-steroidal. So non-steroidal ARP are enzalutamide or bicalutamide, and steroidal ARP are the cyproterone acetate. Anastrozole or letrozole, they are the aromatase inhibitor, finasteride or dutasteride. They are the 5-alpha reductase inhibitors. So goserelin is the luteinizing hormone releasing hormone analog or gonadotropin releasing hormone agonist. Which drugs are the androgen receptor antagonist? Which one is steroidal A or B?
Cyproterone acetate.
Yes,
Cypro-
cyproterone acetate. And which drugs are the non-steroidal A or B?
Azati.
Abiraterone.
No, not abiraterone.
Benzyl.
Non-steroid are
Bicalutamide.
the enzalutamide or
Enzalutamide.
bicalutamide. Okay. And inhibition of aromatase.
Anastrozole. Letrozole.
Yes, either letrozole or anastrozole. And 5-alpha reductase inhibitors.
Finasteride.
Yes, finasteride or
Finasteride.
dutasteride. So these groups of drugs are used in which condition?
benign prostate.
Yes, in case of
BPH.
BPH. And selective estrogen receptor modulator, SERM.
Tamoxifen.
Tamoxifen. Raloxifene.
These are the tamoxifen or raloxifene. Goserelin is a gonadotropin releasing hormone agonist. It initially stimulates the releasing of the luteinizing hormone LH and FSH, leading to a transient increase in the testosterone level. However, with continuous administration, it downregulates the gonadotropin releasing hormone receptor in the pituitary gland, leading to a decrease in the luteinizing LH and FSH secretion. This ultimately reduces the testosterone production, which is beneficial in the treatment of hormone-sensitive prostate cancer. And ARB are the bicalutamide, flutamide or enzalutamide, and they are used in the management of metastatic prostate cancer. And aromatase inhibitors are the anastrozole, letrozole. They blocks the conversion of androgen to estrogen. These are primarily used in the treatment of estrogen receptor positive breast cancer in the post-menopausal women. And inhibitors of 5-alpha reductase, they are the finasteride or dutasteride. They blocks the conversion of testosterone to dihydrotestosterone. They are commonly used in the treatment of benign prostatic hyperplasia and the male pattern baldness. And SERM, tamoxifen and raloxifene, they act on the estrogen receptor. They are used in the treatment and prevention of estrogen receptor positive breast cancer and the osteoporosis. Okay, next one.
An 80-year-old man presents to his GP for an annual checkup. He's interested in medications that will enable him to remain healthy for another 30 to 40 years. The GP explains that he cannot live forever because of the Hayflick limit. What does the Hayflick limit affect? A. Cancer cell proliferation, cellular aging, hormone production, protein synthesis, or vitamin absorption.
Cellular aging.
So what is meant by Hayflick limit? What is meant by Hayflick limit? Definition of Hayflick limit. This is the maximum number this is Hayflick. So maximum number of times a human cell can divide. So this Hayflick limit, this refers to the finite number of times a normal human somatic cell can divide before entering the state of cellular senescence or permanent growth arrest. And this Hayflick limit phenomenon, this is caused by progressive shortening of the telomere, and this shortening of the telomere, this is the protective cap at the end of the chromosome during each of the cell division, and ultimately it will prevent the cellular aging. So with each of the cell division, this telomere, they will become shorter because the DNA polymers, it cannot fully replicate the ends of the linear DNA. So when the telomere becomes critically short, the cell can no longer divide, leading to either cellular senescence or the apoptosis, program cell death. And this cellular senescence, it will contribute to the aging process, as the tissue usually loses their ability to regenerate and the repair. And this will result in a gradual decline in the organ function and increased vulnerability to the age-related disease. And unlike the normal cell, the cancer cell bypass the Hayflick limit by activating this telomere, and this is an enzyme that prevents the telomere shortening, allowing for the indefinite division. So Hayflick limit, it will limit the cellular aging, and the cancer cell, they usually bypass the Hayflick limit, activating the telomere. So this cancer cell proliferation, the cancer cell cannot be restricted by the Hayflick limit because they will cause activation of the telomere, enabling the uncontrolled growth. And hormone production, this is regulated feedback mechanism. And protein synthesis, this is dependent on the ribosomal function as well as the mRNA translation. So with respect to the Hayflick limit, you need to know the definition. The maximum number of time a normal human somatic cell can divide. This is related to telomere shortening. It will affect the cellular aging. The Hayflick limit, it refers to the number of times a normal human cell population will divide before the cell division stops. This phenomenon is a crucial factor in the cellular aging. Each time a cell divides, the telomere at the end of the chromosome shortens, eventually leading to the cell senescence when they become too short. Therefore, the Hayflick limit is directly involved in the process of cellular aging and contribute to the age-related decline in the tissue function. The Hayflick limit does not apply to cancer cells in the same way as it does to the normal somatic cells. Cancer cells often bypass the Hayflick limit via mechanisms such as activation of the telomeres, an enzyme that extends telomeres, allowing them to proliferate indefinitely. And in the original scenario, the answer show you telomere shortening. So the answer was related to the telomere shortening. So the Hayflick limit, it refers to the number of times a normal human cell population will divide before the cell division stops. This concept was discovered by Leonard Hayflick in 1962. The Hayflick limit is a fundamental aspect of cellular aging. It suggests that the cell have a finite capacity for division, after which they enter a state called senescence, where they no longer divide. The Hayflick limit is largely due to shortening of the telomere, which are the protective caps at the end of the chromosome. With each cell division, the telomere shortens until they reach a critical length, at which point the cell can no longer divide. For human fibroblast, the Hayflick limit is typically around 40 to 60 divisions. And unlike the normal cells, the cancer cells can often bypass the Hayflick limit through activation of the enzyme telomerase, which extends telomeres, allowing the cell to divide indefinitely.
A 19-year-old man receives air aspiration for a primary pneumothorax and is discharged from the emergency department. He will travel within 3 months. What activity should this patient be advised to avoid during travels? Boxing, flying, rugby, scuba diving, or smoking?
Scuba diving.
Scuba diving.
So for how long duration scuba diving should be avoided?
Lifelong.
Forever.
So the BTS guidance state diving should be permanently avoided unless the patient has undergone bilateral surgical thoracotomy and has a normal lung function and the chest CT scan post-operatively. So the scuba diving should be permanently avoided for lifetime unless the patient undergoes the bilateral surgical thoracotomy and the patient has normal lung function and the chest CT scan post-operatively. Scuba diving involves substantial changes in the underwater pressure, which can significantly increases the risk of recurrence or complication from a previously treated primary spontaneous pneumothorax. The BTS Society recommends that scuba definitely, unless a very secure definitive prevention strategy has been performed. The differences in pressure during dives can lead to barotrauma and potentially life-threatening condition such as tension pneumothorax.
A 72-year-old woman presents to the GP with her daughter who is concerned about her mother's increasing confusion and visual hallucinations over the past 6 months. The patient has also experienced marked fluctuations in cognition and episodes of pronounced rigidity. On examination, there are signs of Parkinsonism without a significant history of stroke or head trauma. What type of dementia would be most likely to respond to neuroleptic drugs? Alzheimer's disease, dementia with Lewy bodies, frontotemporal dementia, normal pressure hydrocephalus, or vascular dementia?
Dementia with Lewy bodies.
So Parkinson's disease plus visual hallucinations. So most likely diagnosis is the dementia with the Lewy bodies. And this is one of the Parkinson plus syndrome. What are the other Parkinson's plus syndrome?
T-system atrophy, progressive supranuclear palsy, corticobasal degeneration.
So it can have either the progressive supranuclear palsy, also known as the Stille-Richardson-Olszewski syndrome. It can be multi-system atrophy, MSA, also known as the Shy-Drager syndrome. It can be Lewy body dementia. It can be vascular Parkinson's. So PSP will have the features of P. There will be two cardinal features. There will be presence of palsy, especially the vertical gaze palsy. There will be features of postural instability. So you can use the mnemonic PIP front for PSP or Stelly-Richardson-Olszewski syndrome. PIP front, postural instability, impairment of vertical gaze or vertical gaze palsy, Parkinsonism, and the frontal lobe dysfunction. And in case of multi-system atrophy, there would be autonomic features. Autonomic features can be either postural drop of blood pressure, or it can be bowel or bladder dysfunction, or it can be erectile dysfunction. Along with the autonomic features, there can also be associated cerebellar or pyramidal sign. So PSP will have the features of P, vertical gaze palsy or postural instability. Multi-system atrophy will have the autonomic dysfunction, and Lewy body dementia will have the visual hallucination. And vascular Parkinson, this rarely comes in the exam. Parkinson's worse in the legs than in the arms. So erectile dysfunction, this is the early autonomic features of multi-system atrophy. So different types of dementia. Which type of dementia is most common?
Tumors.
Yes, Alzheimer's dementia. Alzheimer's dementia is the most common type of dementia. So there would be progressive memory loss. If you go for CT or PET scan, there would be diffuse cerebral atrophy or diffuse cerebral hypoperfusion, and patient will come with the features of apraxia. A for Alzheimer's, A for apraxia. And in case of Lewy body dementia, there will be features of visual hallucination. How to treat a case of Lewy body dementia? How to treat a case of
Donepezil.
So step 1 should be reduction of dose of the dopaminergic drug, and next step would be you can go for the donepezil, the cholinesterase inhibitors. And in case of multi-infarct dementia, there would be gradual deterioration in the cognitive impairment in the context of either vascular events or cerebrovascular or cardiovascular risk factor. And frontotemporal dementia, they will have the predominant cardinal features is the sexual disinhibition, repetitive checking, and the binge eating. How to treat a case of frontotemporal dementia? Which drugs is commonly used?
SSRI.
Yes, you can go for the SSRI. So they will comes up in a patient with frontotemporal dementia, they will comes up with the sexual disinhibition. There will be bizarre or behavioral changes, repetitive checking, binge eating. There may be history of the professional footballer. If you go for MRI, there would be frontal and temporal atrophy. If you go for PET scan, there would be frontal hypoperfusion. And choice of treatment should be SSRI, either paroxetine or the fluoxetine. And what should be the triad of NPH? Normal pressure hydrocephalus. Triad of NPH.
Urinary incontinence.
Incontinence.
They will come up with the triad
Altered
of
consciousness.
DUG, okay? They will come up with DUG. Where is the NPH? So dementia, urinary incontinence, gait apraxia, or the gait disturbance. And if you go for MRI or CT scan, there would be presence of hydrocephalus with an enlarged fourth ventricle. So initial investigation would be MRI. Initial intervention would be therapeutic lumbar puncture. And in some cases, it becomes very difficult to differentiate the post subarachnoid hemorrhage aqueduct obstruction versus the normal pressure hydrocephalus. So in case of NPH, there would be enlarged fourth ventricle but no papilloedema. And in case of post subarachnoid hemorrhage aqueduct obstruction, there would be normal sized fourth ventricle and bilateral papilloedema. And the DUC triad would be present in both of the condition. So depending on the enlargement of the fourth ventricle and presence or absence of papilloedema, you can differentiate between the two conditions. And in case of progressive supranuclear palsy, we have already stated there would be features of postural instability or history of fall with the pulse, especially the vertical gaze palsy, and the patient will have absence of the resting tremor. And in case of multisystem atrophy or there would be autonomic dysfunction, either orthostatic hypotension, urinary or bowel incontinence, or erectile dysfunction. And as a part of cerebellar syndrome, there may be absence of the gaze palsy. So gaze palsy is always present in progressive supranuclear palsy, but it would be absent in case of MSA. And to differentiate MSA from NPH, NPH will have DUC with no autonomic dysfunction. But in case of MSA, there would be no DUC, but there would be autonomic dysfunction. Dementia with Lewy bodies. This is characterized by fluctuating cognition, visual hallucination, and Parkinsonism. This form of dementia may show some responsiveness to neuroleptic drugs. However, caution is required as the patient can be very sensitive to this medication and may experience severe side effect even at a lower dose. Alzheimer's disease typically presents with the progressive memory loss and cognitive decline, but does not usually involve prominent visual hallucination or marked fluctuation in cognition early on. And FTD, they will have the personality, behavior, and the language changes. And NPH will have the triad of DUG. And in the original scenario, it was a little bit different. They have given the scenario of the Lewy body dementia itself, and they asked regarding the characteristic features. So this 2 point was very confusing. Sensitivity to antipsychotics, sensitive to neuroleptics. So neuroleptics exclusively means the first generation typical antipsychotics, and antipsychotics, it encompasses both first generation and second generation. So sensitive to neuroleptic, this is the more correct answer. So patient with Lewy body dementia often exhibit extreme sensitivity to first generation typical antipsychotic medication, meaning the neuroleptics, which can lead to severe adverse effect, including worsening of Parkinsonism, increased confusion, sedation, and sometimes life-threatening NMS. This sensitivity is a key clinical feature that helps to differentiate LBD from other forms of dementia. However, the antipsychotic medication encompasses both typical and atypical antipsychotics, but the LBD features are pronounced mostly by first generation typical antipsychotic medication, meaning the neuroleptics. So sensitive to neuroleptics, this is the most appropriate answer. Okay, the last one.
A 49-year-old woman presents to the endocrinology clinic with a palpable thyroid nodule and a family history of multiple endocrine neoplasia type 2. She reports recent episodes of diarrhea and facial flushing. Her serum calcitonin levels are significantly elevated. FNC reveals amyloid deposits. What's the most likely diagnosis? Follicular thyroid carcinoma, medullary thyroid carcinoma, papillary thyroid carcinoma, primary thyroid lymphoma, or a toxic multinodular goiter.
Medullary thyroid
So
carcinoma.
this is the patient with main type 2. So with main type 2, the MTC, medullary thyroid carcinoma, this is more commonly associated. So which one is the commonest type of thyroid malignancy? Which one is most
Papillary
common?
thyroid carcinoma.
Papillary
Yes,
thyroid
papillary is
carcinoma.
the most common. And which one is the most aggressive form?
Anaplastic.
Yes, anaplastic is the most aggressive one. The MTC, medullary thyroid carcinoma, is the most likely diagnosis given the clinical context and laboratory findings. MTC arises from the parafollicular cells of the thyroid and is often associated with main type 2. The symptoms of diarrhea and facial flushing are consistent with secretion of calcitonin and other peptides by the tumor. The findings of spindle-shaped cells without follicle development and amyloid deposits on fine needle aspiration is seen in MTC. Spatial analysis of calcitonin within the cells can also be performed to further support this diagnosis. Papillary thyroid carcinoma is the most common type of thyroid cancer, usually presents as an asymptomatic thyroid mass. It is characterized by papilla formation with specific cytological features such as orphan ani nuclei and the samoma bodies, which are not mentioned here. Primary thyroid lymphoma are a rare thyroid malignancy that are often present with a rapidly enlarging neck mass and compressive symptoms. This is not associated with the elevated calcitonin level or amyloid deposit. And the TMN, toxic multinodular goiter, this is characterized by multiple thyroid nodule and hyperthyroid symptoms such as weight loss, palpitation, and the heat intolerance. So what are the components of main type 2B?
Marfanoid habitus.
Medullary thyroid carcinoma, pheochromocytoma,
Chromocytoma. Primary.
Marfanoid body habitus.
And what should be the components of main type 1?
Parathyroid, pituitary, and
Pituitary
pancreatic.
adenoma,
Pituitary,
parathyroid,
parathyroid, pancreas.
pancreatic
So
tumor.
MTC, medullary thyroid
Neuroendocrine.
cancer, pheochromocytoma,
3P.
Marfanoid
3P.
body habitus. These are the
3P.
components of main type 2B. And main type 2, main type 2 is commonly related to MTC, also related to the rate on coaching. And main type 1 will always have the hypercalcemia. Calcitonin can be used as a marker to monitor for MTC in main type 2 in those unwilling to undergo the prophylactic thyroidectomy. So calcitonin is a marker of MTC associated with the main type 2. So whenever main type 2 is suspected, obtain a thyroid ultrasound and serum calcitonin to exclude the medullary thyroid cancer. The neck swelling is concerning for MTC, which should be investigated with a thyroid ultrasound and serum calcitonin. So whenever MTC is suspected, go for calcitonin. Whenever neuroendocrine tumor is suspected, go for chromogranin A. And for carcinoid syndrome, the screening test is 5-hydroxyindole acetic acid. So this is the chart among the different types of main type 1. So main type 1 will have the features of 3P. Parathyroid involvement. there would be features of hyperparathyroidism due to parathyroid hyperplasia, pituitary involvement, and pancreatic involvement, like the insulinoma or gastrinoma. So the ZES, Cholinsson-Ellison syndrome, this is related to which type of men?
Type 1.
Yes, this is
Type
related
1.
to the Chollinger-Ellison syndrome. This is related to the type 1 men as a part of the gastrinoma, and there would be recurrent ulceration, recurrent gastroduodenal ulceration, and this is related to men 1 gene. Commonest presentation is the hypercalcemia, and men type 2, 2A or 2B, they are related to the RET, red oncogene, and in 2A there would be features of 2P, parathyroid and pheochromocytoma, and 2B there would be 1P, only the pheochromocytoma. So MTC, pheochromocytoma, morphonoid body habitus, this points towards the men type 2B. Also, this will be the end of our discussion for today, and inshallah we'll be continuing at the same time tomorrow. So any question from this session?
What time tomorrow?
Same time, 3 p.m. GMT. And most probably
Okay,
you are from
thanks.
India, so it would be 8:30 p.m. in Indian time. Sorry, are you
Thank
from
you.
India or Malaysia?
I'm from Malaysia.
Okay. Sorry, I don't know the exact timing in Malaysia. So you need to
That's
calculate corresponding to 3 p.m. GMT.
thank you.
Okay. Thank you, everyone.
Thank you very much.
Thank you, sir.